The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name's Mark Ryan, and it's a pleasure to be hosting the podcast. And thanks to everyone for listening in. This week's episode is going to be about the Medicare Advantage and Part D advance notice that was issued on January 10th. This advance notice comes out early January of every year for the following year. So in this case, 2026 rates and policies. And what the advance notice does is it puts the public on notice of the rate increases that are expected for Medicare Advantage and Part D, as well as certain policies that are going to be implemented as well. Generally speaking, rules that are put into the Federal Register and publicized and commented on and then finalized is the main area that we get policy. But the rules do allow CMS to issue these advance notices and refine policies or notify organizations about what policies will be put in place and when. So again, the advance notice early January talks about projected rate increases for the following year, as well as some policies. The advance notice will be finalized after comments sometime in early April. So we'll get the final look at the rates and any policies in early April. Generally speaking, not a lot changes from the advance notice to the final notice or the announcement in April, but that could change because of the change in the administration as well. So we'll wait and see what might happen, and I'll be pointing out some areas where there could be some changes. There are a number of tables that go along with this topic that I published in a blog on 113. So to look at the tables as you listen to the podcast or after, you can go to the 113 blog at healthcarelabyrinth.com at the blog tab. So let's get right into it. As I said, on January 10th, the outgoing Biden administration released its advance notice for Medicare Advantage and Part D rates and other policy changes for 2026. The notice will be finalized, as I said, in early April. I've reviewed the 180-page advance notice, the CMS fact sheet on the notice, as well as the CMS press release. So here are some of those key highlights. We'll be taking our normal 3 breaks, so we'll try and break it up a bit here as well. So let's start out with the MA rate proposal. It is likely that MA plans and investors will see the proposed rates for 26 with some relief. After 2 years, it appears MA plans could see a real revenue increase rather than the decreases they saw in 24 and 25. But as plans and financial analysts take a deeper look, the proposal will likely be seen as a very skimpy increase given all the MA world is facing right now. In my mind, the net revenue increase is so low that we will be in store for a third year of MA benefit cuts in 2026. MA rates will have gone up just 0.95% over 3 years when the industry is battling a return of utilization, inflation, and increased costs due to new laws and regulations. For example, prior auth restrictions and the major IRA Part D costs that were not funded by the government and passed on to plans. Benefit reductions and possible contraction of geographic footprints in some form, I think, will be needed by the big national plans going into 26 in order to right their financial ships and meet long-term margin returns that they have promised investors. The proposed rate hike for MA in 26 is a 4.33% average increase if you use the Centers for Medicare and Medicaid Services view, or just 2.23% average increase if you use the plan's view. What do I mean by this? Each year, CMS computes the expected risk score trend into what it views as the rate hike overall. But plans do not see it that way, and the difference is really tied up in the whole overpayment and risk adjustment debate. Plans view the risk score trend from year to year as representing increased risk of the population. They believe these increased risk adjustment revenues will go out in claims costs. CMS and some detractors of MA, on the other hand, see the annual risk score trend as more evidence of overpayment that results in real revenue increases to the plans. Where do I stand on this issue? Well, as you might imagine, I stand somewhere in the middle. Perhaps some of the trends in risk scores could be part of overpayments that need reform. On the other hand, the margins that MA plans have seen of late would show that risk and costs are increasing robustly. I would also note that the projected risk score trend increase is slated to be up just 2% for 2026, which is well below the over 4% trend on average for 24 and 25. This would seem to bolster the plan's argument, at least for 2026. So with that, we'll take our first break, and when we come back, we'll break down some of the component parts of the expected rate increase for 2026. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this edition of the Healthcare Labyrinth podcast. We are talking about the recently issued advance notice for 2026 for Medicare Advantage and Part D rate hikes and policy changes. I promised that after our first introduction, we would start to break down the component parts of the increase that derives the 4.3% in CMS's view, or 2.23% in the plan view's rate increase for 2026. So the first most important part of that increase is what's known as the effective growth rate, or the EGR. The effective growth rate, or EGR, is derived from the growth in the per capita costs in the traditional fee-for-service program in Medicare Advantage for the non-end-stage renal disease populations. It is a national estimate. Trends can be different in each county and region. Remember that the eventual county benchmarks are adjusted from these based on several parameters, including whether a county is at 95% of fee-for-service up to 115% of fee-for-service. For 2026, we saw a huge increase of 5.93% compared with just over 2% in 24 and 25. So clearly, this effective growth rate is much higher for 2026. Trends lag a bit when they're trying to compute this effective growth rate. The 24 and 25 effective growth rates had some of the depressed COVID utilization years in them. Now we are seeing more robust utilization in trends in the effective growth rate calculation as we come out of COVID. This is likely good news for future computations of the effective growth rate as well. The next component part that we like to talk about in this rate formula is what's known as rebasing. Rebasing relates to changes in the average geographic adjustment index, which adjusts for spending differences across regions and counties. This usually is a small impact, and that's what the case is for 2026 as well. The rebasing could be positive or negative in a given year, and actual impacts are really seen at the local, county, or regional level. The rebasing number simply reflects the nationwide impacts of changes in the geographic adjustment index. Rebasing percentage has yet to be set, and it's normally set in the final announcement. But again, this should be very, very negligible. The next area that goes into the computation of this average rate increase of 4.33% in CMS's view is star revenue changes. And again, star revenue changes at the national level are a global estimate. Each plan will have a different result based on its actual star performance by contract and eligibility for bonus revenue. The reduction due to star performance for the 2026 rates on average across the country is a negative 0.69%, the third year in a row of a decline. This is based on the 2025 star ratings, as there is a 1-year lag between the star rating and the payment year. Those losing bonus revenue can see a much bigger year-over-year reduction in revenue. Those maintaining star could see additional revenue due to enrollment growth. Those gaining bonus revenue for the first time or increasing their ratings would see a great jump. The negative number for star revenue is a sign that program-wide plans lost star power and 4-star or above star ratings lately. The next area is the coding pattern adjustment. This is a statutory regulatory reduction taken to MA rates for the perceived differences in risk adjustment scores between MA and fee-for-service. This is all about that overpayments debate. You know my thoughts on this. Again, it is a bit of a mixed bag in my opinion. The coding intensity adjustment has been set at negative 5.91% for years now, and CMS will not change it for 2026. This is despite pressures from critics who say over-reimbursement has risen well beyond the negative factor. Further, CMS likely did not change it again due to the risk model changes being implemented that I'll discuss in a little bit. The next component in the rate setting is the risk model revision and normalization. This really has two parts. First, the normalization factor ensures the average risk score stays at 1.0 and adjusts from the data year in the model to the payment year. This is different than the coding intensity we just talked about. The risk model change is responsible for the biggest impact in the risk model revision and normalization category. In 2024, CMS announced it was updating the risk model and made some very major and controversial changes. First, condition categories were restructured from ICD-9 to ICD-10 codes. Second, the underlying fee-for-service data years were revised. Third, there are some revisions that are focused on reducing the sensitivity of the model to conditions with more coding variation. Last, the new model should reflect more current costs associated with various disease states, conditions, and demographic characteristics. In a concession to plans in 2024, CMS decided to phase in the new risk model change by using 1/3 in 24, 2/3 in 25, and 100% in 2026. So we would be phasing in the final 1/3 in 2026 rates here. CMS is not backing off the final phase-in for 2026. The risk model change certainly hurts. The 3-year impact from the model change combined with normalization, they are very much intertwined, will be a negative 7.62% when fully phased in as of 2026. This is the biggest issue plans have. The risk model change, along with poor star performance, has basically zeroed out the effective growth rate from 24 to 26. On the positive side, the amount reported as overpayments in the future should decline due to the implementation of the new risk model. MA plans had hoped that CMS might suspend the last year of phase-in of the risk model change and defer it to a later year. But CMS said suspending the final year of the risk model phase-in or other medical education change phase-ins would have added $10.4 billion to Medicare costs. The increase, as outlined by CMS alone, will cost Medicare about $21 billion in calendar year 26. Further, CMS estimates the federal government will spend $9.2 trillion over the next decade on MA payments to plans, including $1.3 trillion alone on MA supplemental benefits and premium buydown. The last area of the component of the rate setting I want to talk about is the anticipated risk score trend. And this, again, is a national number calculated by CMS. It can vary by plan for sure. I noted above that plans and CMS view this trend very differently and why plans do not compute it into the rate hike year to year. Note that the projected risk score trend for 26 is about half of what it was in 24 and 25 annually. This is actually a sign that the new model is changing risk scoring patterns. With that overview of the component parts of the 4.33% or 2.23%, depending on who you believe, we will take our next break and we'll get a little further into some other financial details of the advance notice. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about the advance notice for 2026 for Medicare Advantage and Part D rates and policies. I promised that we would get into additional financial details. I wanted to add one other thing before we do that. Let's discuss a little more the dilemma that MA plans have faced the past few years in terms of finances. I talk often about the return of utilization and inflation. We know that plans have had bad STAR results over the past couple of years, and we've talked about the low or negative rate hikes. And as well, there are numerous regulations and statutes that have increased costs. You've heard about this from me on many occasions. So let's talk a little deeper about exactly what's happened from 24 through 2026. So the industry came off of high annual rate hikes early in the 2020s. In 2024, these hikes dropped dramatically, as I told you, due to the risk model change that was being phased in over 3 years, as well as low effective growth rates in 24 and 25. Compounding the problem was a major drop in stars starting in 2023. Lower STAR scores meant less revenue on the rate side. On the cost side, again, utilization and other trends such as drug costs leapt coming out of COVID. As well, CMS has placed new costly burdens on plans, including requiring them to follow fee-for-service prior authorization processes and new unpaid cost from the Inflation Reduction Act's Part D cost-sharing reductions. All of this create a perfect financial storm for MA plans. What makes things worse here is another potential caution to MA plans that is in this advance notice. CMS says it has been working to calibrate the risk adjustment model using MA encounter data, diagnosis, cost, and use data submitted to CMS by MA plans. CMS says it could start phasing in an encounter data-based risk adjustment model as early as calendar year 27. The issue for plans is it would break with setting rates in part on what have been traditionally very high fee-for-service program cost trends. So if MA plans feel like things have been a little rotten in terms of rate setting over the past couple of years, if they do migrate at CMS to a purely encounter database risk adjustment model over time, things could get even leaner. Let's move on to some other financial factors from the advance notice. First, the county benchmark rate percentages against fee-for-service remain the same at a range of 95% to 115% of fee-for-service in the county. Basically, the more urban counties have lower reimbursement against fee-for-service, more rural counties have higher reimbursement against fee-for-service. Number two, the star bonus remains at the same 5% level and applies only to those with 4-star ratings or greater per contract. The rate rebate percentage, which is the difference between the plan base bid and the county benchmark, which goes to added benefits, remains the same based on star performance. If you have less than 3.5 star on your contract, you only get 50% of the difference. If you have 3.5 or a 4-star rating, you get 65% of the difference. And if you have a 4.5 or a 5-star rating, you get 70% of the difference. Fourth, there are no changes to star calculations for low enrollment or new plans. Fifth, Part D risk corridors remain the same. Sixth, given the low rates in Puerto Rico, poverty and penetration in MA, CMS will continue basing the MA county rates in Puerto Rico on the relatively higher costs of individuals in fee-for-service who have both Medicare Parts A and B, and applying an adjustment regarding the propensity of individuals in Puerto Rico with zero claims. Next, CMS is proposing to begin a transition in calculation of risk scores for PACE organizations as a blend of 10% of the risk score calculated using the 2024 CMS HCC model and 90% of the risk score calculated using the 2017 CMS HCC model. In essence, the PACE program will go through the same thing that the regular program is going through with the new risk model right now. The full transition timeframe is also outlined in the advance notice. Last, the advanced notice outlines the changes to Part D cost sharing in the Inflation Reduction Act and their continuing impact on rate setting. Of note is that the first 10 drugs in Part D will have negotiated prices going into effect in 2026. CMS says it will continue the special premium stabilization program it's set up for freestanding Part D PDP plans. I think this is an extra legal program by CMS and was done in the heat of the election season because the agency and Democrats in Congress did not anticipate the huge unfunded spending in the IRA levied on MA and PDP plans. Without the special program, premiums would have soared, and they will when the 3-year program goes away. With that, we will take our last break and we'll come back with a conclusion. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com. your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this outline of all the financial implications and on rates for 2026 for Medicare Advantage and Part D plans. We're just going to come back here for a quick conclusion. And my main question is, could the incoming Trump administration come to the rescue on what's outlined for rates in the advance notice? Again, the finalization of the notice occurs in April, so the incoming Trump administration can look at the advance notice and potentially make changes. And will the Trump administration come to the rescue on rates for MA plans? As I said, some speculated that the risk model might be paused for some time due to the financial issues the MA plans are facing and the erosion of benefits and plan footprints that we just saw in 2025 and could see again in 26. The outgoing administration cites various aggregate statistics it says shows the MA program is stable, but it ignores underlying changes, including the huge displacement during the 2025 enrollment season. As many as 2 million people had to find new plans due to plan changes or terminations caused by the low rates in the model change. This compares with 100,000 people annually on average each year. Some hope again that Donald Trump will come in and make some positive rate changes before the advance notice is finalized in April. While many cite the need to pause the risk model phase-in, the medical education change phase-in actually has a bigger impact. Pausing the risk adjustment model phase-in would result in $3.4 billion in additional payments to MA plans in 2026. Pausing the adjustment to growth rates related to medical education costs would result in additional payments of $7 billion to MA plans in 2026. Could Trump concede one or both of these in the final announcement of rates? Perhaps, but the incoming administration is also busy searching for major spending reductions for extending the 2017 tax cuts. So despite the fact that Trump may be very friendly toward MA moving forward as compared to the Biden administration, he is looking for deep spending reductions to extend his 2017 tax cuts. So only time will tell if any further relief will be given to MA plans for 2026 rates. With that, we'll conclude this edition of the Healthcare Labyrinth podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.